In the next few minutes, we are going to discuss a serious type of anemia, which is aplastic hypoplastic anemia. Its causes, pathogenesis, clinical approach, and therapeutic options for the child with aplastic anemia. It's defined as pancytopenia with reticulocytopenia and bone marrow hypoplasia. Pancytopenia is defined as bicytopenia or true pancytopenia. Bicytopenia decrease in 2 or 3 cell lines. It may suggest ongoing pancytopenia. Pancytopenia is decrease in all blood cell lines. With anemia, hemoglobin less than 11 grams per deciliter, neutropenia, absolute neutrophil count less than 1,500 per cubic millimeter, thrombocytopenia with a platelet count less than 100,000 per cubic millimeter. And this is the bone marrow picture. Normal bone marrow, this is trabecular bones, and there is minimal fat with mainly cellular elements. When the cellular elements are reduced in patients with aplastic anemia, you get expansion of the fat compartment, and this is what we call fatty marrow. Aplastic anemia can be congenital, can be viral, secondary to drugs and chemicals, or idiopathic. Fanconi anemia is the congenital aplastic anemia. It's autosomal recessive. There is pancytopenia not at birth, usually by the age of 4 to 12 years. There is macrocytic anemia. Bone marrow is hypocellular with fatty infiltration. Congenital anomalies are frequent with patchy skin pigmentation, short stature, skeletal anomalies, hypogonadism, microcephaly, deafness, mental retardation, renal and cardiac anomalies. Chromosomal studies show chromosomal breakage and structural anomalies, and there is a higher incidence of leukemia, mainly acute myeloid leukemia, as well as other malignancies. This is a child 3 years old with Fanconi anemia. You see how much he is short. There are cafe au lait spots and hypopigmented patches in the back, and in the hands there is an abnormality of the thumb. This is another picture of Fanconi anemia showing cafe au lait patches, absent thumb, and in this green picture, and in the other picture there is this is what's very evident, what we call clinodactyly of the little finger. Fanconi anemia is diagnosed by cytogenetics. You send the patient asking for chromosomal breakage test. On the chromosomes, there are added clastogenic agents, and they result in chromosomal breakage and rearrangement, and this may occur spontaneously in vivo, and this increases their chances to develop malignancies. I can explain that why in the face-to-face session. The acquired aplastic anemia, there is a well-documented association of viruses with aplastic anemia, including the pyrovirus B19, the HIV, Epstein-Barr, hepatitis C, even hepatitis A and hepatitis B virus have been involved. And the onset of aplastic anemia may be during the acute or the recovery phase, and the course of aplasia is frequently severe and fatal. Exposure to drugs and chemicals is the most frequently cited precursor of aplastic anemia, and there are 2 patterns. Whether the aplasia is dose-related, so it's related to an overdose of the drug or the agent like chloramphenicol, benzene, ionizing radiation, and antineoplastic agents. So withdrawal of the drug can give the chance of bone marrow recovery, or it is not dose-related, it is some form of idiosyncrasy, like with pesticides, some anticonvulsants and antimicrobials like chloramphenicol and sulfonamides. And in these conditions, withdrawal of the drug will be of no benefit. It causes serious disease. Idiopathic is more than 50% of aplastic anemia. There are no identifiable cause, but an immune pathogenesis is suspected, especially that it was found that these patients in the mild and moderate and severe form, some of them, they respond to immunosuppressive therapy. In all cases, aplastic anemia is a serious disease that requires intensive treatment. What are we going to do investigations when we have a patient with pancytopenia? Detailed history of drug, toxin, radiation, family history, blood count, reticulocytopenia is expected, anti-nuclear and anti-DNA and rheumatoid to exclude collagen diseases, liver function test, tuberculin test, bone marrow aspirate and biopsy, cytogenetics, chromosomal breakage test. Viral serology is important for ABC and Epstein-Barr virus, skeletal X-rays and IVP, and chest X-ray to diagnose associated congenital anomalies in Fanconi anemia. And the treatment, number one is avoidance, if the cause is known, supportive care, antibiotics for infection, platelet transfusion for thrombocytopenia and bleeding, red cell transfusion for the anemia. You may give growth factor like granulocyte colony stimulating or granulocyte macrophage colony stimulating factor for the neutropenia. Bone marrow transplantation is the cure. There should be an HLA compatible donor, and related donor is much better than unrelated donor. The use of immune suppression is another option, especially when there are no donor bone marrow transplant. Immunosuppressive therapy for moderate and severe patients with aplastic anemia. This includes animal antisera to the human leukocytes or thymocytes. The possible main mechanism of action includes immune suppression with destruction of the cytotoxic T cells. Hematological response is usually evident within several months. Transfusion independent may be evident by 2 to 3 months, but relapse rate are 5 to 10%, and the response rate is 30 to 70%. Corticosteroids are usually administered in conjunction with ALG or ATG. High-dose methylprednisolone can be used. Other agents include androgens as stimulatory to hematopoiesis, or cyclosporin A as an immunosuppressive drug, and you may use a combination of ATG, high-dose steroid therapy, and androgens, proved to be effective in 74% of the cases. However, remember that pancytopenia is not only aplastic anemia. It may result from bone marrow infiltration in leukemias, lymphomas, solid tumors like neuroblastoma, infiltration with storage cells, storage diseases like Gaucher disease and Niemann-Pick, infiltration with fibrosis like in myelofibrosis. It may complicate disease like marble bone disease. It can result from peripheral blood elements destruction like hypersplenism, Evans syndrome, autoimmune hemolytic anemia and thrombocytopenia, and systemic lupus erythematosus. So differential diagnosis is important to think about. Thank you. Waiting for your questions.